Some of it may be more technical than what you're looking for as a parent. Some of it may not be technical enough if you're one of the physical therapists who are signed on, but hopefully it'll be of some value to everyone who's taken some time out of their evening tonight. So just quickly, I'm going to cover some of the anatomy of the ACL, the sort of rate of ACL injuries, risk factors, how we diagnose it, the treatment considerations, and most importantly, to some extent, how to prevent it, which there's no perfect solution, no smoking gun on that one, unfortunately. So the ACL stands for anterior cruciate ligament. It's one of 4 main ligaments that stabilize the knee. There are ligaments on the inner side and the outer side called the MCL and the LCL. And then in the middle, you have the PCL and the ACL that cross each other, which is how they get the name cruciate for crossing. And what the ACL does is it prevents the shin bone from moving too far forward in relationship to the thigh bone, the femur, and it also supports rotation. So you're using it when you're cutting, pivoting, and generally doing sports. It's a main stabilizer of the knee, which is why it's such a devastating injury when it tears. Some people may have ACL, MCL or LCL sprains. Those heal on their own. ACLs, not so much, and I'll go into a little bit of why a bit later. So not only does it prevent those motions that I spoke of, but in preventing those motions, it helps protect the meniscus from tears, and also protects the other ligaments of the knee, and it provides proprioception, which is knowing where your knee is in space. And that's in part why if you tear your ACL once, even if it's reconstructed, you don't get all of that proprioception back, and it makes you more likely to have another tear in the future. So ligaments are like ropes, and the ACL is no different. This is about 3 centimeters long, which is just over an inch, and 7 to 12 millimeters in width. And just like this rope has torn, it's not torn completely, but you could imagine if this is what your rope looks like, it can't really do what it was meant to do. It can't really give you support. And that's the case with ACL tears. So if you get a diagnosis of a partial ACL tear and you're thinking, maybe I can rehab that, the majority of the time, unfortunately, the answer is no, because once it's incompetent, it's not giving you any support to your knee, and it's just pretty much just as bad as fully torn, unfortunately. So that's kind of where that rope is sitting inside the knee, and the ligaments of the body are what connecting one bone to another bone and keeping them together. And this is what the ACL looks like arthroscopically. So on the left side, that's an untorn ACL. And if you're able to follow my arrow here, it goes up from the shin bone to the back of the thigh bone. And over here, it looks like it's okay, but then it has no attachment to the femur, and you see these torn fibers over here, and that's there are many different appearances of torn ACL, but this is one of the typical ones. So ACL tears seem to have become an epidemic over the last 2 decades, in part because much greater participation of women, teenage girls in sports, and they are higher risk versus 20 years ago, much lower participation, increased year-round sports. So if you're playing soccer on your high school team in the fall, you might be doing some sort of futsal, winter soccer, and then playing on your club team in the spring. So there's many more contact hours of the athlete doing the sport than 20 years ago. And of course, in just the intensive training regimens, and also more recognition of the injury as well. So this type of injury has a huge impact on the society, on finances, on, of course, the child or adolescent who's torn their ACL. So when you've torn your ACL, that is typically a 9-month road to returning to sports. And that's why it's such a devastating injury. And it just doesn't just impact them physically, but also emotionally. And so you're missing multiple seasons of play. It sometimes even prevents them from returning to sports. Sometimes they're traumatized by it even and are scared to return at the level they did before. It has a big financial impact on society and also on long-term health, because down the line, even on the reconstructed knee, there's a much higher risk of arthritis. On the one that isn't repaired, isn't fixed, even higher. So this is just some data on how often ACLs occur in the population. Just know it's a lot. Over 70% is sports related. Usually it's a quick change of direction with often the foot kind of getting stuck or too planted, and then the knee twists, and that's how the tear occurs. Most commonly from ages 15 to 45. And again, in your pivoting sports, teenage girls, much higher risk than boys. Your playing surface makes a difference because turf is less forgiving and you're more likely to get a cleat stuck in there. A prior ACL tear, like I said before, also contributes to that. But not just in the knee that you had the injury before. You are also at much higher risk for tearing the ACL in the other knee once you've had a tear. So the adolescent age group is your peak age. And in this graph, it's comparing females to males, and the solid line is your females. And there's just this huge spike, particularly in girls, from between ages 15 to 19. The boys kind of keep at it at a more slow and steady pace into their 20s, but that spike in girls is where we're seeing all these ACL tears come through. And girls, in most studies, 4 to 6 more times more likely to tear the ACL as boys in the same sports. And even in soccer, sometimes some studies have shown it's 8 times more likely for a teenage girl to tear their ACL. And I'll just touch upon some of the differences because it's interesting. So there are a number of different factors. One, anatomy differences. Hips are wider in your teenage girl, which makes a larger angle, what we call a Q angle, at the knee. So there's more of an angle where the femur, the thigh bone, meets the shin bone, and that increased angle causes you to be just a touch more knock-kneed than the boys and puts you at higher risk. Also, the inside of the knee where the ACL sits, that's called the notch. It's a little narrower in girls than in boys. So the thought is that as the knee twists, it hits the side of the notch more commonly and is more likely to tear. Then there's the impact of hormones, with estrogen causing more looseness of the ligaments. So the knee is more likely to get into a position that puts it at risk for ACL tears, more of that twisted position, because the looseness of the ligaments allows the joint to move further and it's harder to correct from that point of no return. And studies have shown that there are times during the course of the menstrual cycle even where girls are at higher risk than at other points in the menstrual cycle. And then finally, brains are wired differently. That's what we call neuromuscular differences, the messages that the brain is sending to the muscle. And it results in girls landing in a more of a knock-kneed position rather than the knees straight ahead. And not just because of the anatomy, they're just landing differently. And that also makes girls a little higher risk. There we go. And so when it's injured, a lot of times I'll hear from parents that, oh, no one banged into them. I don't understand how they could have torn their ACL. Well, that's actually the most common scenario. 70% of the time, it's a non-contact injury. You got your ski caught and it twisted, or your shoe, your cleat was caught on the turf and your knee twisted. So more often than not, it's a non-contact injury, but that other 30% of the time, oftentimes it's a slide tackle in soccer and football that will get you. So this is just showing sort of the position, the dangerous position, the knee and where that red line is, where you're more of a knock-kneed position and more likely for that shin bone to rotate in relationship to the thigh bone and the ACL to tear. And this is just showing basically the same thing, but on a more skeletal version of the picture that you just saw before. And so it's very difficult to say initially whether someone has torn their ACL or not. A knee could be swollen because of a bone bruise. It could be swollen because of a meniscus tear, which is often a surgical injury, but a much faster recovery than the ACL. But a lot of it is what the athlete told you. Sometimes they'll say, I felt a pop. Now, that might not be the ACL. That could be another ligament in the knee that'll heal without surgery, like the MCL. But often what distinguishes that ACL from those other type of ligament injuries and from the meniscus injury is that they feel like they can't trust their knee underneath them. So they feel like it's wobbly, like it's unstable. And sometimes once the knee swells up and they can't put weight on it, they really can't sense that anymore. But shortly after the injury, before it really swells up, they'll feel like their knee just won't work underneath them. So if I have an athlete who says, yeah, I felt a pop, I was down, and then I got up and I was able to finish the game, but by the end of the game, I was really hurting. The chances are very slim that that person tore the ACL, because no matter how high your pain tolerance might be, you can push through a tremendous amount of pain, but what you can't push through is a knee that won't remain stable under your body as you're cutting and pivoting. So that really will distinguish in some sense. I don't think I've ever had an athlete get up and be able to continue playing when they've torn their ACL. But of course, swelling, stiffness, weight-bearing difficulties, and sometimes the sensation of the pop, but you could tear your ACL with never having felt a pop. So in a more chronic scenario where, let's say, they ignore their symptoms initially, which is usually rare in your high school athlete, what will happen is the swelling will subside, and then they don't have pain anymore. So they may think everything is fine because they're not hurting. But what they'll find is the knee doesn't feel, again, stable underneath them at all times. They can walk around on it. They might be able to jog on it. But if they do any cutting, pivoting, it's not there for them. So what I just spoke about, the history is a big part of it. And then on examination, it can run the gamut. Usually there's a lot of swelling, but sometimes I'll get kids who come in and they only had the injury an hour prior and there's really no swelling yet. Or once in a blue moon, I'll even get somebody the next day who just didn't swell up after the injury. It's rare, but there's no one thing on exam that's definitive. There's a test called the Lockman exam where we kind of pull the knee back and forth to try to get a sense of, do we feel the ACL stopping that forward motion or not? Sometimes it's very reliable and I can get a good feel in the office of, oh yeah, I felt that good endpoint, that ACL is intact. And sometimes you feel like there's extra motion, but it's just because of, some looseness of other ligaments and you're not getting a great sense in the office. So oftentimes we end up, if there's this high suspicion of an ACL tear, we get an MRI because that will tell us pretty much definitively whether or not that tear is present. Now, if our suspicion is low, we may wait because you're not going to have surgery for 4 to 6 weeks after the injury. And so we might say, if our suspicion is low, you know what, let's give it a week, see how things look, and then go get the MRI. If the suspicion is high, then we'll just go get the MRI initially. And what these arrows are pointing to, this white arrow in the picture on the left, it's pointing to an intact ACL. So it shows up as a nice sort of thin band. And the one on the right, you're not seeing any band because that ACL is completely blown out. So in many cases, there will be other injuries which would be taken care of the same time as surgery if they're surgical, like a meniscus tear. There may be some other ligament injuries, which most of the time do not require surgical repair. But if it's full tears of multiple ligaments, then multiple ligaments are going to need to be either repaired or reconstructed. So this is a question that a lot of people ask is, well, will a torn ACL heal? And the short answer is no. So when somebody sprains an ankle, what you're doing is you're tearing the ligaments around your ankle, and those heal just fine. When you tear the MCL around the knee, that typically heals just fine. The difference with the ACL and also the PCL is that inside the knee, there's joint fluid. Almost all our ligaments elsewhere in the body are outside the joint, and joint fluid never touches them. Inside the knee with the ACL, it's bathed in this joint fluid. And what that joint fluid does is it washes away the blood clot that forms when you tear your ACL. Now, that blood clot has all the stem cells and everything you need for your body to heal it. And it just can't do it because of the joint fluid that's there. So is there a role for non-operative treatment in an ACL tear that won't heal? Yes, but not really in my patient population. And by that, I mean that if you're taking kids who are in their teenage years, even one who's not doing sports, that abnormal motion of the knee, that instability of the knee, long-term will lead to much earlier onset of arthritis. As you get older and generally a little bit more sedentary on average, and it takes you maybe 20, 30 years after an ACL to set in, you might not, if you're in your 40s or certainly less so in your 50s, go for that ACL reconstruction, as long as your knee isn't giving out on you on a regular basis, and be absolutely fine. But in the younger kid, athlete or non-athlete, the reconstruction is generally what is recommended. Bracing does not reduce the rate of re-injury, unfortunately. So, as I said, teenager generally needs to go ahead with surgery. If there's other injuries, meniscus tear, cartilage injury, certainly, regardless of age. So again, every time you have some buckling of the knee, there is abnormal motion, damage, slow but steady damage to cartilage, and eventually meniscus tears and significant arthritis. So initially after the tear, just that typical RICE treatment, rest, ice, compression, elevation, crutches only if needed, brace for comfort. And then we actually do physical therapy before we do surgery. So a lot of kids come in, they find out they tore their ACL and they said, okay, let's do this surgery yesterday, because they want to get back to sports as soon as possible. But the outcomes of surgery are much worse if you operate too fast, which again is why we kind of say, if the suspicion is low, let's give it a week and see. Because if you don't have full motion of your knee, or at least are able to have fully straighten your knee and bend it most of the way, you're much more likely to have a complication from the procedure, that being permanent stiffness of the knee, the technical term arthrofibrosis, where you just can't move it because you've had this buildup of scar tissue. So we really want to wait till the optimal time to perform surgery. And the best way to get you there the fastest is to do physical therapy first, and then go to surgery before continuing physical therapy afterwards. So the goal of surgery is to restore that stability of the knee, create a functional knee, and prevent that stiffness or arthrofibrosis. So repairing the ACL, like I said before, because of that blood clot being washed away issue, that's pretty rare, but there are a couple of exceptions. There's a form of an ACL injury, I don't want to say tear, where instead of the ACL tearing, the ACL pulls off a little piece of bone. So the ACL itself isn't torn. And what we can do in those cases is repair it back into place and hold it down with a pin or a screw. And that way we can kind of repair the ACL. But again, it's not truly technically the ACL that got torn there. Then there's also a newer technique called the bare ACL. And what that does, the rehab is the same and everything, but the difference is you don't have to take a graft for the ACL, because even if you try to just sew the ACL back together normally, same issue with it just being torn. It won't heal because it doesn't have that blood clot there, those stem cells there to do so. With the bare ACL, what we're now capable of doing is taking this foam insert, filling it with blood from the patient, and sewing it to the ACL. And that foam keeps those stem cells there so that the ACL can repair itself. Now, the rehab isn't any faster, but what that benefit is that you're not taking graft tissue, you're not taking the quad tendon, patellar tendon, anything like that to repair it. So you still have all those other structures of your knee intact. Long term, this is still a new procedure. It's gaining popularity. So long term, it's hard to say what the jury will say on it, but it is a very exciting development. So when we do these ACLs, we do it mostly arthroscopically, but you always have to make an incision to take that graft. And so it's not fully arthroscopically. The graft options are different tendons in the body. I personally don't like hamstring because it stretches out. And quad tendon and patellar tendon are your most popular graft options right now. And then there is always the option of taking a donor graft. Donor graft, the downside is that there's a slightly higher re-tear rate. But if you're someone who's maybe of college age, you're not at all an athlete, you're working, you're going to school, you want to get up on your feet the fastest, it might be a good option, because since you're not using your own tissue for the new ACL, you're going to feel better significantly faster. In case you were wondering what the graft looks like, this little picture kind of shows you where we take the patellar tendon from. We take a piece of bone, a small piece of bone from the kneecap, small piece of bone from the tibia, and that central third of the patellar tendon, which may beg the question, well, are we now going to see tendon tears because of this? And surprisingly, the answer is no. There's a slightly high risk of fracturing the kneecap afterwards, but we also kind of put some bone graft in there to help lower that risk. And personally, I've never seen, knock on wood, kneecap fracture from an ACL reconstruction. And this is basically what your graft looks like in real life. And there's no better graft versus, quadriceps or patellar tendon. It's somewhat surgeon preference and somewhat based on the age of the patient too. If your growth plates are open, you can't take patellar tendon because those bone pieces will close the growth plates. Quad is a great option. And as I alluded to before, using donated tissue can be a good option for certain patients. So when we do the surgery, we take out the old ACL and we put in the new one. Simple as that. And that's what your graft looks like once it's in there. And then in the rehab piece of it, you're minimizing swelling, working on mobility, and then the rest of the time, really those last 6 months of rehab out of those 9 is really getting your strength back and agility back and trying to minimize that risk of any re-tears. And like I said, initially I discussed prevention, but there's no great, smoking gun that's yet to be found. Bracing does not diminish the risk of ACL tear preventively. There has been a study that shows that a brace can diminish the risk of MCL injuries, which are, again, just sprains, non-operative. In football linemen, they tend to be your highest risk people for MCLs. So bracing in that population for that injury has been helpful, but it really doesn't diminish your rate of ACLs. And then there's neuromuscular training programs that you can't address the estrogen issue, you can't address the anatomy issue, but you can address the neuromuscular issue. So there are training programs to teach young female athletes how to better land and almost retrain, give them more muscle memory as to that proper landing technique to diminish the risk of ACL tears. Is it helpful? Yes, probably. There have been some studies that show some good results, but you have to stick to it, which is the difficulty. Like the coach has to almost guide it or lead it, or of course, the physical therapist. And with that, that's all I've got. Thank you very much for your attention. And I turn it over back to Dr. Lynn. I guess if there are any questions.
I think you can unshare your.
Oh, yes, I will do so.
Okay. Thank you very much. That was excellent. Excellent overview of ACL injuries. If you guys have any questions, please stick it in the chat box, and we'll try to answer whatever we can. And while we're waiting for any comments or questions, Dr. Friedman, can you just comment on, since we are pediatric orthopedists, just a general overview of how we treat these kids differently depending on how older they are, how skeleton mature they are, because that is what makes us a little different.
Yeah, absolutely. So while ACL tears are essentially an epidemic in the teenage population, we get patients that are preteen. I think the youngest in our practice, correct me if I'm wrong, was 5 years old. And so the wider open the growth plates, the more differences we need to do in the surgery to protect those growth plates. So for our youngest patients, generally 10 and under, we will take a strip of the IT band, which is this thick tendon on the side of your thigh, and wrap it around where the ACL goes, completely avoiding any type of drilling through growth plates and avoiding them basically all together, so that we're really not risking any damage to the growth plates, because the younger you are, the more devastating it is to have any type of growth plate injury. In your tween age group, as they get closer to teenagers, we'll use a soft tissue graft like that quad tendon, so that there's no bone, because if you put bone through a growth plate, you're going to stop the growth. So in that age group, we might go through the growth plate still, but with just soft tissue. Or if they're kind of around that 10, 11 age where the growth plates are still kind of wide open, we may, but they're big enough that we can get around them through bone, we'll go almost under the growth plate and around it in order to avoid it. And then once you get into your kids who are fully grown, then it's essentially the same procedure as your adult patient, but with more of an emphasis on getting them back to sports than you would with the adult.
It's a difficult question to answer since we have many tools in our toolbox on how to fix these kids. One of the hot topics, as you mentioned, is this bear technique, which actually just came out about a year and a half ago. And so we've done a few of them. The jury's still out whether they work just as well as what we normally do with our reconstructions. And once again, as you mentioned, no one knows long-term how these kids do. So it is a unique option, but it has to be for the right patient and the right family, because they have to understand that it is a little bit of a trial period for that implant. There's no questions in the chat room. We may end this early. Okay, so we're partners at the Pediatric Orthopedic Center. We have 8 full-time pediatric orthopedists, and we do have a question. Hold on a second. Let me see. Here we go. Oh, okay. So there's a question in immature bone in adolescence. How can you make a reconstruction of the ACL tear? How do you make the tunnel?
Well, I just sort of allude to that, but I'll give you a little bit more specifics. So there are 2 ways, depending on how old there's actually more than 2 ways, but 2 general ways is, again, you can take that in the really immature patient, you can take that iliotibial band, which is on the outer side of the knee, and then you wrap it around the back of the femoral condyle. It's called wrapping it around the over the top position. And then instead of attaching it right where the old ACL was in the middle of the shin bone, the tibia, we attach it in the front of the tibia. So we're not drilling any bone tunnels whatsoever. The downside of that is that it's not as anatomically perfect as your native ACL. And when that procedure was developed by Ming Coker in Boston, he thought it would be a temporizing procedure, meaning that these kids were all going to need a traditional ACL reconstruction when they got older. And it turns out very few of them did. It worked really, really quite well. So that's how we get to avoid bone tunnels in the youngest ones. And in the tweens, we can kind of go just below the growth plate, since their bone is big enough that we can make a tunnel there. But again, it's not a perfect ACL reconstruction because it's not as anatomic as when we can go through our traditional bone tunnels and through the growth plates.
Okay, and also just a follow-up, since the person who made this brought this question up seems to be a orthopedic specialist in Libya. Welcome. We also have techniques where we can make drill tunnels through the epiphysis, through the ends of the bones, away from, so we're not crossing any growth space. We can actually put the grafts and anchor them in the epiphysis at the very ends of the bones, away from the growth space. But that takes some special techniques and tools that not everyone unfortunately has. Second question, and actually this is up your wheelhouse, Samara, since you are a baseball fan. So one, I guess one father here has a son who just had ACL reconstruction on his left knee. He's a baseball player and golfer, and this is his lead knee when he plants. Is that an issue with the torque and stresses?
So yeah, so he's a righty pitcher then, and it really should not be an issue for him. Yes, the stresses across the knee are significant when you're pitching in baseball. But if Mariano Rivera can do it, I'm sure your son can too. And again, I mean that not facetiously, but literally, because if you want to talk about stresses across the knee and landing, pitching a baseball, someone throwing 100 miles per hour plus is going to put extreme stress. And he came back beautifully after his ACL. So it's really more the cutting, pivoting than the stress. Like, I know there's some turning of the leg as you're kind of twisting your body over that lead leg as you're pitching, but it really isn't the same stresses as cutting and pivoting. So I would really not have concerns about his ability to return to baseball and return to golf.
I think they may be asking about the planting. Once you land, you're going to kind of torque around, maybe.
Yeah, but it's still not the same as like that
Right.
cutting on turf. I would be more concerned about the football player than the baseball player by far.
Right. We definitely see more football players than pitchers or baseball players. Okay. I have another, I think, young lady, 13 years old, just had surgery this past August. How can you best avoid a re-injury, since she has 4 more years of high school and then college, and she likes lacrosse, soccer, and basketball?
Oh, you got some real ACL killers there. Yeah, all those sports are cutting, pivoting sports. And thank you for the question. It's a great question. And the best way to prevent it is really through that rehab piece and having your physical therapist work with you on landing with your knees pointed straight forward, with your body weight centered over your foot rather than over the front of your knee. So your physical therapist should be familiar with some of those exercises that help you land properly and diminish that risk. Other than that, I'd say wearing your ACL brace afterwards can be helpful, but it doesn't make a tremendous difference. But that being said, it made somewhat of a difference. So do wear it, particularly for your cutting and pivoting sports. But the best thing is working on jumping, landing, and quadricep strength.
Right. And then the one thing we see is that a lot of times when we have these kids, finish their rehab and they're cleared for sports, they let all that part of it go. They don't continue with the exercises, the stretches, the things that they've been working on all year. They think that they're all healed up and they're good to go. But it's good to maintain all that. That's probably the best way to try to prevent another injury. Samara had mentioned that neuromuscular training may be helpful. So it's so if you want to look something up, you can go on YouTube. It's called one program is called FIFA 15 or 14. FIFA. It's the Federation from Federation of Soccer, and it's a very quick video. It shows you how to spend like 10-15 minutes before practices and games to kind of hone in on how to land correctly, how to work your muscles such as your quads and hamstrings, and that has been shown to provide some protection to your knees, not 100%. But it's very simple, and if you can keep that up, that also may be very helpful. Great questions. anything else? Otherwise, we will, I guess, end this little
A couple more, I
meeting.
think a couple more questions have shown
Oh,
up.
I'm sorry.
Quickly,
Not
what
scrolling.
sport has
I
the
apologize.
highest
Okay, go ahead.
ACL incidence for girls? Soccer. Soccer has the most, but basketball is not far behind either.
Okay, and oops. And sorry about that. No, not scrolling. And okay, so for a sport such as soccer, and it probably doesn't matter which sport, but what's the preferred time frame to go back to play after surgery?
So generally, it's approximately 9 months. We used to clear people at about 6 months if they had enough strength at that point in time. But there was recently, not even recent anymore, about 4 or 5 years ago, a study that showed that for every month longer that you wait, irrespective of physical therapy, the risk of re-tearing went down. And that was most significant from month 6 to month 9. So now, no matter how good you're really looking, we really like to wait 9 months, because that alone, that waiting time, will diminish your risk of re-tearing. Now, if you're really not at full strength at 9 months, which can happen for a number of potentially different reasons, then it may take a little bit longer. So a full year might not even be unusual.
Okay, and so the same person, the father who had the son with the baseball and golf interests, was asking about certain types of exercises, exercise sleds while pulling, knees over toes. Have you heard of this?
I think that's probably more of a physical therapist question. So on specific exercises, you probably, the person with the most expertise on that would be a therapist who works on rehabbing ACLs. But really any exercise that helps with balance, that helps with quadriceps and hamstring strength is going to be helpful for someone in protecting their ACL or ACL graft, as the case may be.
Okay, I just have a comment. Someone asked me about the FIFA. If you Google like FIFA 14 exercises or FIFA 14 ACL, and you'll see it, and there's a lot of videos on that. And then we'll have to end it here, but any supplements seem to help?
None that I'm aware of, and if you find ones that claim to do so, they're probably just wanting you to get into your wallet.
Got it. Okay, so out of respect of just keeping on time and honoring everyone's time and experience here, I'd like to end this here. If you would like, you can contact our office anytime. You can leave messages. We can get back to you. But I thank you all for your presence here, and hopefully this was helpful. And if you have any topics you'd like us to cover in the future, we'd be happy to do so. All right, we'll end it tonight. Have a great one. Good night.